Oscar Health, an insurance technology company, soaring over the last 2 days after topping earnings estimates on the top and bottom line. Joining us now, Mark Bertolini, Oscar Health CEO, to break down the numbers, as well as our healthcare reporter, Anjalee Khemlani. Mark, thank you so much for being with us. It is fantastic to see you, first of all.
And
your numbers really interesting. In particular, I saw a lot of commentary around your costs being better than estimated. So first, I just wanted to kick us off with you telling us a little bit about that, how you sort of got costs down to beat the street and what contributed to that.
Well, there are two pieces to it. One is the leverage of growth. We've grown since I joined by almost 1 million members in the last 2 years. So that's part one. But part two is that we have been using large language models for a number of years now. Our founders have a relationship with OpenAI. Josh Kushner, who's one of our founders, actually was one of the first investors in OpenAI. And so we've been using these models. And prior to this year, we had implemented 20 large language models, and then we're implementing 10 so far this year, where we have reduced our operating costs by 1,660 basis points.
Mark, it's Anjalee here. Really good to see you again. Talk to me about that and how Oscar is really doing this, in a field where you're competing with some of the larger insurers. I know, there aren't as many competing in the ACA marketplace as before, but you have been focusing a lot on technology. Oscar's reputation started there. So how does what Oscar is doing, is it scalable? Is it something that we can see, some of these large vertically integrated organizations kind of mimic, considering that they are struggling with costs right now?
Well, Anjalee, the biggest part about implementing AI at scale is that you have to have a single version of the truth in the data set. And so Oscar, by its history, is the first new health insurance platform to be built in the industry since 1972. And we have a single source of truth on the data. So we don't have multiple versions of Mark Bertolini running around, thank God. And so the whole idea is if we have a single version of the truth, we can use that data effectively. Now, we didn't start on the clinical side right away. We started in the back office, and we started on things like making information available for members. So in 2024, in January, we grew by 600,000 lives. We did that with 200 less people and better service standards than we did the year before when we grew by 100,000 lives. So the model is what can we do to get people information more quickly? How can we support our brokers in enrolling members into our plan? All of those sort of backroom kind of things that make it simpler and easier to do business with us. This year, we've implemented some interesting models. We have one that intakes people and gets us a sense of their conditions that they want to address. It allows us then to provide support through our virtual medical group to help them get that care. The other is sort of what I would call a symptom checker. So think of back in the day, WebMD and others coming forward with all this online information. We now have a chat bot that allows you to take you through the symptom checker in a way to say, okay, what do I do next? What do I need to do? What do I need to understand?
Fair. And I know you and I have talked a lot about, how insurers are operating, how the entire industry really needs an overhaul. And this is just an example of that. I want to talk about also, we saw your former place exit the ACA marketplace. And I know you're focusing a lot more on ICHRA right now, but talk to me about what that does really for the entire marketplace and what that means for members and their, what's available for them.
Anjalee, one of the interesting things that is I've worked here for the last couple of years and understood the way people buy a couple of important things. The more players in the market, the better. In large part because everybody has narrow networks in the Affordable Care Act. And narrow networks allow you to get a lower price point because you're moving revenue to fewer players and they get share as a result. That is counterintuitive to what we do in the employer market, where you have large numbers of employees and you have large networks, which actually have higher cost points. So if you have more players and they all have narrow networks, and currently today, 75% of physicians in the US are in the Affordable Care Act networks somewhere. If I'm a buyer, instead of me having to buy what my employer offers me, I can buy at a better price point as an individual in the individual market because I can find my network with my plan design that works for me. The plan design is important because it's about my risk and what I need to cover. Whereas with an employer, they pick an average down the middle for their employees, and nobody likes to be considered to be average, but we have fewer solutions to pick from. And given that in the ACA now, 95% of all enrollment growth comes through a broker, brokers are helping us get people into the right plans. So that's why the individual market works better from a cost point. That's why the more players in, the better, because we have access to the providers that anybody needs. So our view is we don't need to get all the members. We want the members that need our products and our networks. We want to serve them well at a price point that for the last 3 years has been below or at the cost of inflation.
Mark, I want to ask you beyond Oscar, though, because obviously, as Anjalee mentioned, you're a veteran of the industry. You led Aetna for more than a decade, or you were at Aetna for more than a decade. It feels like, to many, at least for many patients, they feel like the system is broken, right? They're not happy with it. This is not new. We've seen it bubble up in new and dangerous ways over the past year or so. What do you think is sort of the biggest issue there? What's the biggest challenge? What needs to be fixed the most?
I think it's so we've moved healthcare beyond population health and beyond disease management to individual health. And individual health means I need to have my provider that I use, and I need to have my product that works best for me. Those are the important things for me as a member. So if I can find my doctor in a plan design that allows me to cover what I need to get covered, instead of what my employer buys for me, which isn't bought all that cost effectively, versus what can happen in the individual market, I'm better off. So a lot of the things members complain about is prior authorizations, or all the things that, if I know what my concerns are for my health, I know what I need, why am I having to go through the insurance company to get it approved? So there are products that are now being launched that allow people to have frictionless care, and those frictionless care models allow me to get what I need on my terms at my cost. And that's what, everywhere else in our economy we can get that. In healthcare we can't. Somebody else buys it for me and tells me, here, you have to use it, and oh, by the way, I want you to pay 15% of the premium.
Yeah, that sounds like a good summary of what people don't like about it. Mark, we got to leave it there, unfortunately.
Why is this so hard?
We always love talking to you, so come back again and talk to us soon. And thanks, of course, to Anjalee as well.
Good to see you both.